Raymond was 54 years old and had never been to a cardiologist in his life. On a Tuesday afternoon in October, he felt what he later described as a burning sensation in his chest after lunch. He sat down. He took an antacid. He told his wife it was probably the chili they had eaten the night before. He lay on the couch and watched television. He felt a heaviness settling across his chest, a strange dampness on his forehead, an ache spreading into his left arm. He told himself it was stress. He had been under considerable pressure at work for months. By 8 o'clock that evening, nearly 6 hours after the first symptom, his wife called 911. At the hospital, Raymond was told that a portion of his cardiac muscle had already died. Not because he failed to feel the warning, because he felt it perfectly and dismissed everything it was telling him as indigestion. Raymond's story is not unusual. It is in fact the story the data tells repeatedly. Studies consistently show that the average time between the onset of heart attack symptoms and arrival at a hospital emergency department is between 2 and 4 hours. 2 to 4 hours, during which the cardiac muscle supplied by the blocked artery is dying cell by cell, zone by zone, at a rate that determines how much function the heart will have for the rest of that person's life. Today we are going to go inside what a heart attack actually feels like. Not the version from television, the dramatic clutching of the chest, the sudden collapse. The real version. The one that arrives quietly, that masquerades as something completely ordinary, that gives people 6, 8, sometimes 12 hours of warning that most people explain away until it is almost too late. I am Dr. Sofia Ramirez, and after today, you will never look at indigestion, jaw ache, or unusual fatigue the same way again. What you're about to hear is educational information based on published scientific research. It is not a substitute for personalized medical care. If you have heart disease, high blood pressure, diabetes, or any risk factors for cardiovascular disease, please work with your doctor before making any changes to your routine. And if you experience any of the symptoms we discussed today, do not finish this video. Call emergency services immediately. And if this is your first time on this channel, subscribe right now before we go any further. Because the symptom presentation I am going to describe in the section on women is the one that kills more women than any other single cardiac presentation. And it is the one that most women and some of their doctors still do not recognize as a cardiac emergency. Subscribe and stay with me through every section. Let's begin with the biology of what is actually happening inside the heart during a cardiac event, because the experience of the symptom only makes sense when you understand what is generating it. The most common type of heart attack, a type 1 myocardial infarction, begins not with the blockage itself, but with the rupture of something that was already there. For years, often decades, cholesterol-laden plaques have been building inside the coronary arteries, the vessels that supply the heart muscle with oxygenated blood. These plaques develop inside the artery wall and are covered by a thin, fibrous cap. The plaque may moderately narrow the artery, but the artery compensates over time. Blood continues to flow. The person feels nothing unusual. Then the cap ruptures. The contents of the plaque, oxidized fat, inflammatory cells, cellular debris, are exposed to flowing blood. This triggers the coagulation cascade. Platelets rush to the site. A clot begins to form rapidly. Within minutes, that clot can grow large enough to partially or completely obstruct blood flow through the coronary artery. The cardiac muscle supplied by that artery begins to receive less oxygen than it needs. Then none. What happens next is a cascade of cellular events that the heart muscle experiences as profound distress. Without oxygen, the cells switch to emergency anaerobic metabolism. Waste products accumulate. Electrical signals within the cells become unstable. The cells begin to swell. Within 20 to 40 minutes of complete oxygen deprivation, cardiac muscle cells begin to die irreversibly. The area of dying muscle is called the infarct zone. How large it becomes depends almost entirely on how quickly blood flow is restored. Time is muscle. Every minute of complete coronary occlusion costs cardiac muscle cells that will never regenerate. The treatment that works, restoring blood flow through a catheter-based procedure called PCI, or percutaneous coronary intervention, is dramatically more effective at 60 minutes than at 4 hours. It is meaningfully effective at 4 hours, and it becomes increasingly less effective from there. A study published in the New England Journal of Medicine analyzing outcomes in heart attack patients found that each 30-minute delay between symptom onset and restoration of blood flow was associated with a measurable increase in 1-year mortality. 30 minutes, not hours. The biological clock starts the moment the plaque ruptures and the clot forms, which means the only clock the patient can influence is the one between feeling the first symptom and calling for help. Subscribe right now and stay with me, because I am about to describe what that first symptom actually feels like in the body. And it almost never matches what most people expect. Here is what a heart attack actually feels like, not in the movies, but in real bodies, described by real patients. The Hollywood heart attack is sudden, dramatic, and unambiguous. A sharp stabbing pain in the left chest, a collapse. It is vivid, it is unmistakable, and it is unrepresentative of the way the majority of heart attacks actually present in real people. The actual experience is frequently described not as pain at all, but as a pressure. A heaviness, a sense of squeezing, tightening, or crushing across the central chest, not localized to a single point, spread across the sternum and sometimes radiating outward from it. Patients use the words elephant, vice, band, and tight. They say it feels like someone is sitting on their chest, like their chest is being squeezed from the outside, like a weight has settled there and will not lift. It is deeply uncomfortable, but it is not the sharp, piercing, unmistakable pain that people have been primed by decades of television to expect from something as serious as a cardiac event. Why does the heart produce this sensation rather than a sharp pain? Because the heart muscle has no pain receptors of the type that produce sharp, precisely localized pain signals. It is innervated by visceral afferent nerve fibers, the same type of fibers that carry sensations from the stomach, the esophagus, the gallbladder. Visceral pain is inherently diffuse, poorly localized, and experienced as pressure or aching rather than as sharp stabbing. The brain receives the distress signal from the ischemic heart muscle and interprets it through the same neural circuits it uses for digestive discomfort. This is the reason millions of people have sat with a developing heart attack for hours, holding an antacid, waiting for indigestion to pass. A study published in Circulation analyzed symptom descriptions from hundreds of heart attack patients and found that only a minority described their primary symptom as pain in the classic sense. The majority described pressure, tightness, squeezing, heaviness, or fullness, sensations that fall well outside most people's mental image of what a cardiac emergency feels like. The practical implication is this. If you feel a diffuse, heavy, squeezing, or tight sensation across your central chest, particularly if it lasts more than 5 minutes, if it comes and goes in waves, if it is accompanied by sweating, nausea, or unusual breathlessness, and if it does not clearly resolve when you change position, you are looking at a cardiac symptom until proven otherwise. Not indigestion, not a muscle, a cardiac symptom. And the response to a cardiac symptom is a phone call to emergency services, not an antacid. Now let's go through the most common things people in the middle of a heart attack tell themselves they are having instead. The most common misidentification, the most deadly, the one Raymond made. Here is why the indigestion confusion happens so consistently. The cardiac muscle of the left ventricle and the lower esophagus share overlapping sensory nerve pathways. The vagus nerve, one of the primary autonomic pathways involved in both cardiac and gastrointestinal function, runs in proximity to both structures. When the ischemic heart sends distress signals along these shared pathways, the brain's sensory cortex locates the sensation in the region it associates with those fibers, which is the upper abdomen and the lower chest. Not necessarily the center of the chest, the upper stomach, the area just below the sternum, the epigastric region. The result is that a significant proportion of heart attacks produce symptoms that are genuinely, authentically indistinguishable from indigestion, not because the person is being careless, but because the two conditions share a sensory landscape. The burning quality, the upper abdominal location, the nausea, the belching, the feeling that something eaten recently is sitting badly, the instinct to take an antacid and lie down, What distinguishes cardiac epigastric discomfort from gastrointestinal indigestion is the context and the behavior of the symptom over time. Gastrointestinal indigestion usually has a plausible dietary explanation. It tends to respond to antacids, position changes, and passing time. It does not progress. It does not produce cold sweating. It does not cause lightheadedness or a gathering internal sense that something is wrong that the person cannot fully name. Cardiac epigastric pain often has no clear dietary cause. It does not respond to antacid within 15 minutes. It tends to persist and sometimes intensify. It may be accompanied by pallor, a cold sweat, fatigue out of proportion to what is happening, and a quiet internal alarm that is real even when the person cannot articulate exactly what feels different. A study published in the American Journal of Emergency Medicine found that patients who presented with indigestion-like symptoms as their primary complaint were significantly more likely to be sent home without cardiac testing than patients who used the word chest pain, even when their eventual diagnosis was acute myocardial infarction. The language used to describe the symptom affected the clinical response. The word indigestion delayed the evaluation that would have caught the heart attack. The rule stated plainly is this: indigestion that does not respond to an antacid within 15 minutes and that is accompanied by sweating, unusual fatigue, pallor, or any discomfort radiating to the jaw, arm, or back is cardiac until proven otherwise by a physician with an ECG. That is not an overcaution. That is the standard the evidence supports. Now let's talk about a presentation that accounts for a significant proportion of delayed cardiac care in adults over 50 and that almost never gets discussed as a heart symptom: anxiety and panic. And the overlap is real. Both cardiac events and panic attacks produce a rapid heart rate, a sense of chest tightness or pressure, shortness of breath, sweating, lightheadedness, and a feeling of dread or impending doom. The symptom clusters are nearly identical at the subjective level. And a person with a history of anxiety is primed by that history to interpret ambiguous physical distress through the framework they already know. Here is how to tell them apart, because the distinction is knowable, even in the moment. Panic attacks typically build rapidly to a peak, often within 5 to 10 minutes, and then begin to resolve. They frequently arise in the context of identifiable stressors or anxious environments. They tend to improve with breathing techniques, with removing oneself from a stressful environment with the passage of 15 minutes. The person's colour remains normal. The sweating, if present, feels emotionally driven rather than cold and inappropriate. The chest tightness often fluctuates with the level of psychological distress. Cardiac events do the opposite. They do not resolve with breathing. They do not improve with calming the mind. The physical sensation persists and often quietly intensifies, independently of the person's emotional state. The sweating is cold and breaks through even when the person is lying still. The pallor may be visible to someone else. And critically, the symptom that began as mild may steadily worsen over an hour or two, even when the person has fully convinced themselves that it is anxiety passing. A study published in Psychosomatic Medicine found that patients who initially presented with panic-like symptoms and were treated only for anxiety without cardiac workup had a measurably elevated rate of subsequent cardiac events compared to matched controls. A meaningful portion of what is treated as panic in emergency settings is cardiac in origin. If your panic does not resolve within 15 minutes with standard calming strategies, or if it is accompanied by cold sweating, jaw or arm discomfort, and a central chest heaviness that feels physical rather than emotional, you call emergency services. You can be wrong and feel briefly embarrassed, or you can be right and be alive. Now let's talk about a biology lesson that most people receive too late. The heart receives its sensory innervation from spinal segments that also carry input from the skin and muscles of the left arm, the jaw, the neck, the upper back, and the left shoulder. When the ischemic heart sends distress signals along these shared spinal pathways, the brain, which is better at locating sensation on the body surface than in internal organs, sometimes projects that pain to one of these peripheral locations instead of, or in addition to, the chest. This is referred pain, and it produces some of the most consistently misidentified cardiac presentations in emergency medicine. Jaw pain that arrives without dental cause, dull, diffuse, persistent, coming and going over minutes, is a referred cardiac symptom, especially if it appears during exertion, during emotional stress, or at rest in a way that feels unrelated to teeth, gum, or jaw joint. A dentist appointment is not the right first response when this symptom appears alongside any other cardiac sign. Left arm heaviness or ache, not a sharp pain, but a dull leaden quality in the left upper arm or forearm, sometimes extending toward the little finger side of the hand, is referred cardiac pain that most people attribute to sleeping in an awkward position, to lifting at work, to carpal tunnel syndrome. In isolation, it may be just that. Alongside sweating, chest pressure, or nausea, it is a cardiac signal. Upper back pain between the shoulder blades, acute in onset, not clearly related to a specific physical movement, present at rest, accompanied by sweating or central chest discomfort, is a less recognized but documented cardiac presentation. A study published in the Annals of Emergency Medicine found that a meaningful proportion of confirmed heart attack patients had presented with back pain as a primary or sole complaint without chest pain and experienced significantly longer delays to treatment as a result. The myth to address here directly is that a heart attack without chest pain cannot be a heart attack. That is incorrect. Jaw, arm, back. These are established cardiac pain locations with documented clinical prevalence. They are more common in women, in people with diabetes, and in older adults, the exact population most at risk for serious cardiac events. Stay with me because the next section is one of the most important I have ever recorded for this channel. It is specifically for every woman watching this and for every person who loves a woman over 50. What I am about to tell you is the cardiac information that the research says women are least likely to receive and most likely to need. Heart disease is the leading cause of death in women. Not cancer, heart disease. And yet a well-documented gender gap in cardiac outcomes persists, in time to treatment, in accuracy of diagnosis, and in overall survival. It persists in large part because the symptom presentation most common in women during a heart attack is the presentation that is most easily explained away. Women are significantly more likely than men to experience what the research calls atypical cardiac presentations, which is itself a misleading term because these presentations are typical for women. They are only atypical relative to the presentations that were historically studied almost exclusively in male populations. The presentation most associated with a female heart attack is this: a profound, unusual, and unexplained fatigue qualitatively different from normal tiredness not accounted for by recent activity or poor sleep. A fatigue that may arrive days or weeks before the acute event. Nausea, sometimes vomiting, shortness of breath that occurs at rest or with minimal exertion, a sense of pressure or squeezing that may be located not in the center of the chest but in the upper abdomen, the jaw, the neck, or between the shoulder blades, and a gathering sense that something is wrong, an anxiety that feels physical and organic, not psychological, that the woman may not be able to name but that her nervous system is generating for a reason. The classic central chest pressure that dominates public awareness of heart attack symptoms is less frequently the primary complaint in women. And without it as an anchor, both the patient and sometimes the clinician may not reach for a cardiac frame. A study published in Circulation found that women experiencing acute myocardial infarction were significantly more likely than men to report nausea, fatigue, jaw pain, and back pain as primary symptoms, and significantly less likely to report classic chest pressure. The same study found that women waited longer before calling for help and that this delay directly worsened their outcomes. A separate study published in the New England Journal of Medicine found that women under 65 were 7 times more likely than men of the same age to be discharged from emergency departments without a cardiac diagnosis after presenting with symptoms that were subsequently confirmed to be a heart attack. 7 times. The practical implication for every woman watching this is non-negotiable. Unusual unexplained fatigue paired with any combination of jaw discomfort, shortness of breath at rest, nausea, or back pain between the shoulder blades, you call emergency services. You do not attribute it to stress. You do not attribute it to hormones. You do not wait to see if it passes. And the implication for the men watching is equally direct. If the woman you love describes feeling unusually unwell, different from how she normally feels, and she seems pale or her breathing seems off and she attributes it to stress, you take that seriously. You help her cool. Now let's talk about an event that affects nearly half of all cardiac patients and that most people have never been told about. A silent myocardial infarction is a heart attack that occurs without the person recognizing it as a cardiac event. The symptoms are either absent or so mild and atypical that they are completely dismissed. A brief afternoon of unusual fatigue, a few minutes of jaw discomfort, a fleeting episode of shortness of breath, and the person carries on. The infarction is discovered later, sometimes years later, on an ECG or cardiac imaging study that reveals the characteristic scarring of a previous event that was never treated. The American Heart Association estimates that approximately 45% of all heart attacks are silent. Nearly half. Half of all myocardial infarctions occur without the patient ever receiving treatment because the event was not recognized as an event. Who is most likely to have a silent heart attack? Adults with diabetes whose altered pain perception from neuropathy may blunt cardiac symptoms. Women, for the reasons already discussed. Older adults in general, whose pain perception may be reduced by age-related neurological changes, and people who attribute vague symptoms to something else and move on. A study published in JAMA found that adults who had experienced a silent myocardial infarction discovered on cardiac MRI in a research setting had a significantly elevated risk of cardiovascular mortality compared to adults with no prior infarction, despite having no awareness of the event. The heart muscle had been damaged. The electrical conduction had been altered. The risk profile had changed. And none of it had been known, addressed, or managed. If you have cardiovascular risk factors and have experienced in recent years any unexplained period of profound fatigue, brief jaw or arm discomfort, or an episode of shortness of breath you attributed to something else, raise this directly with your physician. Ask whether cardiac imaging is appropriate. Ask whether your current ECG shows any changes consistent with a previous ischemic event. Now, before I give you the final piece of what a heart attack actually is, I need you to understand something important. Every section we have covered so far has been about recognizing a cardiac event during the event itself. What I am about to tell you is different. It is about the days and weeks before the acute event arrives. It is about the warning system the heart deploys before the plaque ruptures, a warning system that exists in most cases and that almost no one has been taught to recognize. This is the information with the greatest potential to prevent the event from happening at all. Do not leave before you hear this. A heart attack does not arrive without warning in most cases. In the majority of patients, the heart has been sending quieter, easier to dismiss signals for days and sometimes weeks before the acute event. These pre-event signals are called prodromal symptoms, from the Greek word prodromos, meaning running before. The most consistent prodromal symptoms documented across the research are these: an unusual non-exertional fatigue, a tiredness that does not match activity level, that does not respond to a full night of rest, and that is qualitatively different from normal tiredness in a way the person may struggle to describe, but clearly recognizes as new. Shortness of breath in situations that would not previously have produced it, climbing a flight of stairs that was never a problem, walking at a pace that used to be comfortable. Disturbed sleep, in particularly episodes of waking with chest discomfort or breathlessness that resolves when sitting upright. And a recurring vague physical discomfort, an intermittent epigastric unease, a dull jaw or arm heaviness, an occasional sensation across the chest that comes and goes over days, never fully developing into something alarming enough to act on, and for that very reason, never acted on. A study published in Circulation followed women who had experienced a myocardial infarction and found that more than 70% reported prodromal symptoms in the weeks before the acute event, most commonly unusual fatigue, sleep disturbance, and shortness of breath. The majority had not recognized these as cardiac warnings. The majority had not reported them to their physicians. A parallel study in men published in the American Heart Journal found that over half of male heart attack patients reported new or worsening symptoms, most commonly exertional discomfort and unusual fatigue, in the 4 weeks before their acute event. The pre-event window existed. It was felt. It was not acted on. The analogy I want you to hold is this. A dam under structural stress does not fail without warning. There are small cracks in the concrete. There are subtle changes in the flow. The engineer who knows what to look for can identify the pre-failure state before the catastrophic event. The prodromal symptoms of a cardiac event are those cracks. The question is whether you and your doctor know what they look like. If you have had, in the last 3 to 4 weeks, any combination of unusual fatigue, new or worsening shortness of breath with exertion, sleep disturbance with nocturnal chest discomfort, and intermittent jaw, arm, or epigastric discomfort, schedule an appointment with your physician, specifically framing these as potential cardiac symptoms. Ask for an ECG. Ask whether a stress test or cardiology referral is appropriate. You do not need to be having a heart attack to access cardiac evaluation. You need symptoms that warrant it, and the symptoms described above warrant it. Share this video right now with someone who has been brushing something off, the husband who calls it indigestion every evening and hasn't mentioned it to his doctor, the mother who says her unusual fatigue is just the change, the friend who keeps mentioning his jaw aches and hasn't made the appointment. Share it now before the close. Then come back for the 2 minutes that turn this from something to watch into something to act on. Here is what to do in the next 48 hours based on what you just learned. Today, identify and write down your cardiac risk factors: high blood pressure, diabetes or prediabetes, high cholesterol, smoking history, family history of heart attack before age 65, obesity or physical inactivity. The more of these are present, the lower your personal threshold should be for calling emergency services when any of the symptoms in this video appear. Risk changes what a symptom means. Know your risk level. Today also, save emergency services in your phone in a location you can reach immediately. Then sit down with the person you live with and have the conversation this week. Tell them what the real symptoms of a heart attack feel like. Tell them that jaw pain, back pain, nausea, and unusual fatigue in combination are cardiac symptoms. Tell them what to do. Call, do not drive if you describe any of those things. The conversation itself is a cardiac intervention. This week, if you have had prodromal symptoms in the last 3 to 4 weeks, unusual fatigue, new shortness of breath, recurring indigestion that won't resolve, intermittent jaw or arm discomfort, schedule a physician appointment specifically framed as a potential cardiac concern, not a general checkup, a specifically stated cardiac concern. Ask for an ECG at that visit. At your next appointment, ask your doctor to calculate your 10-year cardiovascular risk using the pooled cohort ASCVD calculator and explain what the result means for the aggressiveness of your current management. A number, a plan, and a conversation change outcomes. You now know that a heart attack does not feel like the movies. It feels like indigestion that an antacid doesn't touch, like an anxiety that breathing doesn't resolve, like a jaw ache with no dental explanation, like a fatigue so different from normal that you notice it but cannot name it, and that all of these sensations can arrive days and weeks before the acute event, giving a window that most people do not know is a window and do not use. Subscribe to this channel right now, because in the next video we are going to cover the 5 cardiovascular numbers that every adult over 50 needs to know. Not the ranges your doctor calls normal, but the specific values that the research in high-risk populations says actually protect the heart and brain over decades. These are the numbers that predict a cardiac event years before it happens. Subscribe now and do not wait for someone else to send it to you. I will see you in the next one.